incongruous is no movement and they're idle. Right, so if you probably remember these two quite quickly. That's not going to spend a little bit of time just making sure you differentiate. First, let's talk about what is this. The synovial joint. So one side I'm going to talk about distinguishing features. So this is what makes a joint a synovial joint. And there are 6 features. What are some? What's right? No, those are going to be types of joints, right? So first we'll talk about mix. Yes, the first definition of a synovial joint is the cavity, fluid cavity, right? But there are other features that make synovial joints that you're going to find in all synovial joints. What were the smallest bones in our body? In our ear. In our ear too, between the bones is synovial joints. Okay, you can have all these features there as well. Okay, which is pretty cool. Okay. So what are some features? I mentioned about the space, right? The joint cavity. What's in this cavity?
Fluid.
What kind of fluid? Synovial fluid. Where does the synovial fluid come from? It's a filtrator plasma. It's got a little extra things. Some things not. What produces obstruction? Which will be one of the features. 2 parts. One of the parts will produce the synovial fluid. So joint capsule, right? Capsule. This one, right? Capsule. It has 2 layers. What are the 2 layers and how are they oriented? Outer is the fibrous layer, which usually has the nice distinguishing feature of keeping it separate, and then the inner layer will be the synovial membrane. This is what produces synovial fluid. It's facing the inside, so facing the cavity. Right? What else? As joints hurt when we injure them, and nerves and blood vessels, again, in no particular order. It also bleeds very easily. What's that? The ends of it's cartilage. So articular cartilage. And then we have ligaments. What are ligaments? They connect bone to bone. What kind of tissue are they made of? Dense regular. We have some ligaments within joints. We'll talk about one joint, one of the ligaments that. What's a bursa? Fluid filled sac. What kind of fluid? Synovial fluid. Where is it found? Yeah, so they're outside of the joint, but they help the joint. Right? They could be wrapped around tendons. They could be a bit low. For example, there's a nice big bursa just underneath that clavicle, which helps movement. Right? Takes off some of that stress during movement. We talk about fatty pads. Where are fatty pads found? Those are inside the joints, right? What are some functions of fat? And of course, connective tissue? Cushioning. So that's what here is going to be. Yes, it does insulate. What else is function of adipose? So is triglycerides. Insulates as well, right? So we talk about heat. Talk about What are the different types of synovial joints? And also it says hinge joint, pivot joint. That's a planar joint. We'll talk about gliding the movement. Saddle joint. Ball and socket. And then condyloid or ellipsoidal. Alright. Where can we find hinge? Elbows and knees. Which two bones in the elbows are hinge joint? Everybody has lab on their skeletal system. Now, maybe structures. Which two bones does this form the hinge joint? Well, now, humerus. What landmarks are there? Trochlea and the trochlea notch. What's that? Wrench-like structure. But then the trochlea. It's trochlea is actually a little cylindrical structure. We saw it almost like a dead little cannon, sort of can. That will fit the trunk of the ulna. That becomes a hinge joint. Okay. Our knees, even our interphalangeal joints are also hinge joints. Where can we find pivot joints? Two places, please. Not exactly the shoulder. The neck where? Between the first and second cervical, so atlas and axis. Good. Where else? Where about? Which is which side? The elbow is proximal. It's also a pivot joint. Good. Planar joints. Between carpals and tarsal bones is a planar joint. Even between, what are the two parts, the clavicle and the scapula? What two parts, landmarks meet together? Ulna and clavicle and the scapula.
This is the AC joint,
Yeah, what is that?
the acromion.
The acromial process, and the acromial end. Right, we talked about those two. That's a planar joint. Just right. Whereas all other movements come from our ball and socket joint and shoulders. Saddle joint, only one place we have them. Base of the thumb, between what bones? With that last, connect those together. Maybe you want to know one of the bones, but at least the bigger name of it. Group. The metacarpal and the, not the scaphoid. Scaphoid is actually lower down. But you're on the right track. It's the carpal and the metacarpal. Right, so it's right here. Scaphoid is even the second one down. It's the trapezium we talked about. It's the first carpal and then metacarpal. I mentioned one ball and socket. Where are the two ball and sockets? Shoulders and hips. Right? So this allows multiple movements to talk about. Condylar joint, condyloid or ellipsoidal. I think of these as a smaller version of ball and socket. So they do allow a little more movement, right? Like at this joint. What will that be? Between what bones? Meta, carpals, and what phalanx? Proximal phalanx, right? So that is also condylar. It's like a small version. There are certain movements, a lot more movements than this one, right? That just does that. Good. So today we're going to talk about some movement and two of our joints which do get injured a lot. Okay? So gliding movements is between planar joints. Okay? So from side to side, back to forth. Think about your ankles moving just like on. You know, we have lots of different joints with it, but the ones between the tarsals just move side to side. Same with our arches too, just side to side. If we do all this, it's between, mostly it's actually with that movement. It's also an ellipsoidal joint that's between the radius ulna and the carpus. Keep all the carpus together. Okay. Well, next we're going to talk about some angular movements. So for lab, next week onward, it's going to learn muscles and learn the action of these muscles. So when they contract, what kind of movements, and we'll be using these terms to describe. Okay? So we're going to talk about angular movements. So again, it's not easy to show in images, so I'm going to walk you through it. So this is kind of the resting position, right? So you bend your head forward, for example, that's called flexion. So you're decreasing the angle between it. Generally, flexions is in this front kind of plane. There's some which go in the back or posterior, that's what you want. Okay, but generally, so flexion of fingers, flexion of phalanx, right? Flexion of your wrists, flexion of elbows, flexion of shoulders, flexion of neck, back, right? What about knee flexion? That's actually going to move backwards. That's still a flexion. Hip flexion still forward, but knee flexion is actually backward. The ankle's there. Okay? So the angle reduces between the joints. That's flexion. So in this picture, or these two pictures, this person going from this position to this forward position is flexion. Same resting neutral position to that forward position is flexion. The opposite, going back to natural position, is called extension. Okay, so from a flexed position, we extend. So for example, what muscle is here? Tricep, and we'll learn it's called triceps brachii. Which movement does it do? When it contracts, what does it do? Extension, right? This one will be the one for flexion. We'll talk about this one next lab. Okay? So flexion is forwards, while extension increasing the angle, but going up to the neutral position. Some joints we can go beyond neutral. Elbow we can, or generally we can. There might be a few, maybe one or two people that might be able to do this, right? But generally that does not go beyond the norm. But what about our shoulder? Yeah, we can go beyond, right? So coming from here up to here is extension. Okay. Same thing with our neck too. From a flexed position, going back to the neutral position. Okay, or normal angle position. But we can go beyond it. What does it mean? More hypertonic, right? What does hyper mean? More, right? So it's hyper extension. We don't call it flexion. It's just going beyond that. And here is there. Okay. We should be able to flex our wrists, shoulders, neck, back, hips, not knees, not wrist, right? Most people can, some people can extend the fingers. Not all can. Right? Generally, we do not hyperextend our fingers, but we can the wrists, yeah, shoulders, back, back. So it's going from this neutral position and neutral position further back. That's hyperextension. This is going back to the original. Okay, flexion, decrease in angle, extension, increase in angle, up to the anatomical position. We go beyond it. That's hyperextension. Okay. So in this case, it's going from this natural position to back. Natural position to back. Then next we're going to talk about, again, two, if you will, in terms of opposing directions. One is called adduction, one is called abduction. Here, even one letter wrong, well, different words, 0 points, right? So pay attention. Abduction and adduction. If I said somebody was abducted away, what happened? Taken away, right? So if you think of a natural anatomical position, you move your arms out, that's abduction, abduction. You bring it towards the midline of your body, that's adduction, abduction, adding to the body, okay? Moving towards the midline, adduction, moving away from the midline, abduction. Generally, we're talking about midline of the body, but it could be different too. For example, fingers, we can abduct and adduct. Right? Abduct. So here is the midline of the palms and so on. Okay. Legs, moving your legs out to the side would be abduction, and then bring it back. Adduction. Okay. So here, adduction would be coming from this position towards the body. The opposite would be adduction, abduction. Away. So from this position, away from the middle. And we can do the same with the legs too. As your fingers, you can abduct and adduct. We'll learn some muscles, deltoid muscle. Which way will it do? Again, hold one of your deltoids, move that arm out, bring it back in. Is it abduct or adduct? Abducts. Will be one we learn from deltoid muscles actually will be abduct. The arm or the shoulder. Okay? With our arms, we can also just make a circle. That's called circumduction. Okay, so here we do a circle with the distal end of your arm, your foot, your leg, and that's circumduction. That shows that it's really a ball and socket joint as well as all these axial movements. A deduction towards the midline, adduction, a deduction, abduction away. Next one, rotation here. It's a little bit, you have to keep mindset so straight. In anatomical position, you turn your head towards the right, that's lateral rotation. Then you bring it back to the middle only, right? That's medial rotation. If I look to my left, that will be lateral rotation again, right? So it's about the longitude axis. Okay? So lateral rotation away, right? Moving to the side, either side will be lateral rotation, medial rotation towards. You can legs too, lateral rotation. You can find if they have a neck or femur fracture, they're not. They are remain in a laterally rotated position to make sure they're most comfortable. Mostly, sometimes you find them in a medial position, but usually it's not. We can make those movements with our arm too. Again, this is the axis. Outwards. When it's inwards, medial rotation, outwards, lateral rotation. Arm from this position to that. Palms of the arm, lateral rotation. Coming from this way to the inside, medial rotation. Questions? Okay. Next one, these are special movements. So, supination, pronation is similar to supine and prone. Which way is the supine position?
Face down.
Face up, right? Your spine is down. So that way it's palms forward, and then pronation is palms downwards, right? I'll give you this example. People remember this just as a thing. Oliver Twist, they go up. He wants more soup. How is he holding his bowl? Supinated position, right? So supine and supination is palms upwards, and then pronation, anteriorly, pronation, palms downward or posterior. So going from this to this, supine, and from that to that. Pronation. So what do joints help us to do that? Supination and flexion. It's two joints. It's not the wrist actually that includes now. It's at our elbow is mostly, right? So what kind of a joint will help us make that? Pivot joint as well as the interosseous membrane, the syndesmosis of supination. Okay, next one's with the foot. So here, please pay attention. What foot is that?
Left.
Left foot, because they're gonna go in opposite sides, this movement, okay? So we're gonna talk about, so that's the sole of the foot this way, so the big toe, right? So if this was the right foot, let's do the left foot like it is, right? So inversion, sole of the foot faces inwardly, eversion, sole of the foot faces outwards, right? So this one, this will be eversion, inversion, right? So inwards, inversion or medially, inversion, laterally, eversion. Okay. And then sole of the foot, so foot itself is another movement as well. Toes up, toes down. What's the top of our foot called? Dorsal surface, right? So it's this one, both are flexion, by the way. It depends on where the angle we're looking at. Okay? Dorsiflexion is toes up. So the dorsum of the foot is where we're flexing towards. While the other way from natural flexing, put our toes down. Right? That's plantar flexion. Plantar fasciitis, the sole of our foot. Right? So plantar flexion goes inferiorly, dorsiflexion goes superiorly. Okay, near the foot. Okay. Dorsiflexion, plantar flexion, dorsiflexion. And with our hands, if we can touch the thumb to any other finger on the same hand, that's called opposition. You may have heard cats and dogs, they cannot use instruments because they do not have opposable thumbs, right? They cannot touch the same, the fingers of the same hand with the one that we can, so we can use instruments. So that's opposition, when we bring the thumb to touch the other fingers on the same hand. And there's no opposite direction, we don't actually have a definition for it. But opposition is when we touch. Then we can move certain parts of our body in towards the front, anterior, or towards the back. This one is demonstrated the mandible, right? You push your mandible out. That's protraction. You can push your shoulders out too. And then retraction, you pull them back in. So protraction, you protrude a part of the body anteriorly. Okay? While retraction, you take it back, pushing backwards, posteriorly. Mandible, we can do that. We can touch shoulders. Okay? And while we're at the mandible, if we can raise it up, right, all the way down, mandible, shoulders, we do the same. One is called elevation, which way?
Up.
Up. And then we go down, it's called depression. So if you open your mouth, that you're depressing the mandible. Close it, you elevate. And what joint here is going to be the main joint? TMJ joint. That's an interesting one because hinge shouldn't allow that, but it's more like a hinge. But that one somehow it also lets it drop down. Hinge is what we open properly, but there is a little bit more down. It's strange. That's why I didn't give that a little hinge. It's more like a, yeah. It's got some characteristics of all its stuff, but it's not. Any questions before we move on to our two big joints where there's other structures? Okay, so first we're going to talk about our knee. Okay, so knee has two pairs of ligaments and then a pair of menisci. So what two bones do we have in our shin? Tibia and fibula. Which one is the bigger one? Tibia. Which one's the medially located one? Tibia is located medially, right? So let's say that tibia. Looking at somebody else's. Let me draw the fibula here. Okay, so that's my drawing of a knee joint. Okay, that's to show the femur, tibia, fibula. If you were looking at someone's knee, they're facing you. Which knee is this one? Left or right?
Left.
Left one, right? Because this is the medial bone. That would be their left. Okay, so this is on the left side. If you're looking at somebody else's. So we have two collateral. I know we are used to doing those short ones, which you might see, but we have write out the full words of them, okay? So we have two collateral ligaments. Collateral means on the lateral sides. The one we have here. Let me try it. Do I have enough colors? I don't know if I have 6 different colors, but we can get some done. This one is good, just so it is. So MCL, that stands for medial collateral ligament. That's a common one to tear. Again, please write the full word. Medial collateral ligament. The other one, we don't use the shorthand so much, that's lateral collateral. If I said another name for one of this is tibial collateral ligament, which one would it be? Tibial collateral.
MCL.
Medial one would be the tibial one. Okay, fibula one is this one. So that's another name for this one. Tibial collateral. One will be fibula. So I'll say this is number 1, this is number 2. What's brown? 1 or 2?
1.
1. That's on the same side as the tibia. Another shorthand you may have heard of is ACL. Very rarely do we say PCL, that's the other one. But there the C's are not the same. Okay, but the A and P you might guess, what is that?
Anterior posterior.
Anterior posterior. Okay. So anterior, it's cruciate. That's That's our ACL. Shorthand also, so we recognize them. And again, please use the full name. I ask you to list it, please list full. We should have some space here. Let me see if I can make a little more room. Actually, between tibia and fibula. We have tibia and our femur. So, one is in, they're not like this. They're not on opposite poles of the knee. They're both at the back of the knee, but they're just crisscrossing each other. Okay? The front one is the anterior cruciate ligament. Behind will be the posterior cruciate ligament. Why do we have more MCL tears than we do lateral collateral? Think about, again, what is a ligament? What kind of tissue?
Tense regular.
That's regular connective tissue. When do they tear? When the force is not in their normal direction. Normal direction is this way, okay? So they tear when there is force. So when we fall, so medial collateral ligaments on this side, right? Generally if we fall like that, okay, that's stretching up the ligament, that's when we just tear the MCL. Okay? Because it landed with their foot outside, laterally, stretch out the medial collateral. That's a lot more common than lateral collateral ligament because usually when we do this movement, our hip takes most of the work, so we don't generally tear that. ACL, PCL, again, similar. When we stretch backwards, it's the anterior one that gets ripped. Okay, stretch the knee out. So I have a picture, I'll show you. They're like crisscross. The one in front is the anterior cruciate, and the one in the back is the posterior cruciate. How many menisci do we have? Two. That two, they're really sitting on the tibia. That also we can use two names for them. You can see a disc here. Okay. We also say lateral and medial menisci. We also say tibial and fibula. Not so much. We usually use the lateral and medial meniscus, right? So what's the orange one?
Lateral.
Lateral meniscus. The blue one would be the medial meniscus again. Tibia, medial side. Fibula, lateral side. So let's look at this image. Yeah, it is. So this is which leg? Left or right there?
Right.
Right leg, right. That's the medial side. Tibia is the medial side. Back to here. So that's fibular collateral, or what's another name? Lateral collateral ligament. This will be tibial collateral or medial collateral. Two cruciates are inside, they're not on opposite sides of the knee. Anterior being in front, and the posterior goes behind, and you usually tear this more often. You can see the menisci, lateral menisci more on the fibula side, medial menisci on the medial side. And they're both on top of the tibia. Please be able to recognize them. Be able to label, but definitely be able to just understand what that is. This way you can understand it like. Next one is the shoulder joint. Okay, there, yes, we can. So which one's more likely to dislocate, shoulder or hip?
Shoulder.
Shoulder. Why?
It's looser. It's looser. It doesn't have as much to hold in place
Yeah,
because the hip
remember-
socket is enclosed. The shoulder socket is just kind of in place with the scapula and the platform.
Yeah, so what two landmarks make the ball and socket joint in our shoulders? Again, revising that. The other one, it's called the fossa, it's cavity, the space between, yeah, and the humerus, right? Whereas in our hip joint, what two structures? Acetabulum, a lot more rounded, right? And then the head of the femur. Do we still dislocate our hips? Yeah, still happens, right? So by design or by evolution, we have got more muscles that does help our shoulders, and we try to prevent it. Okay, not always possible. It does dislocate more often than not, right? So we need to recognize the rotator cuff. Okay, these are 4 muscles that helps to stabilize our shoulder joint. Okay, once SITS is starting letters of the muscles, recognize them, be able to list them. In terms of where exactly they're located, I'll talk about it here, but I'm not expecting us to know, but you may find it useful in your clinical setting. So, do we remember where the spine of the scapula was? Yeah, it's at the back here, right? So, supraspinatus, where do you think that might be? Yeah, it's above the spine. That's basically the name comes from. It's above the spine. Infraspinatus, below the spine. While subscapularis is underneath the scapula, so kind of the inside facing the chest wall, and subscapularis. Okay. A 4th one, teres minor, goes from the scapula kind of below where infraspinatus is attached, and then joins here. Here, this is not good. This difference in colors. Teres minor is here. That's our spine of the scapula. Supraspinatus, infraspinatus, teres minor. The last one's on the inside, so on the chest wall itself. Again, they're connecting to the humerus, trying to keep that attached to the scapula, right? That's subscapularis. Okay. These are the 4 muscles of our rotator cuff. Please be able to list them, right? If we tear one or more, of course, dislocation chances are high. We can diagnose it by if they can move their pain, but how much movement and where they can move, right? Again, too much for us, but certain parts they will not be able to move this, but they can move that, okay, depending on what you rupture. And then you'll see what they do is they'll hold their arm, they'll fling their body over, and then they'll move. Okay. Others, they can do that. Mostly they have some movement here, usually because multiple joint, but they can't move far higher. Right? So, then you might go through this with your trauma. Okay? You might go over this. But recognize there are 4 muscles that form our rotator cuff, right? So the names: supraspinatus, infraspinatus, subscapularis, and teres minor. So let's talk about the 2 commonest forms of arthritis. Okay, so all of us probably will get this form. This is the wear and tear form. That's osteoarthritis. Okay, what's happening as we move our joints a lot? There is wear and tear. It's cartilage loss. Okay, there could be some fluid loss in our joint cavity. There's cartilage loss. That's when we actually start experiencing the pain. When we go no cartilage or very little cartilage, now we have bone on bone. You may have heard that. That's because of cartilage. So in our generation, we are likely to get arthritis more in our hands. Why? Yeah, lots of gadgets. Right? We're probably going to get thumbs and so on. It's very common, and still common. Hips, knees, shoulders, common to get because we use it. So wear and tear kind of thing. Bone spurs, I think it's because of rubbing the little bony pieces that kind of pull out. Right? moderate acute pain. This is a wear and tear. Well, rheumatoid arthritis, that's the next. Again, we have multiple different arthritis. These are top two, I would say. Rheumatoid arthritis, maybe you want to classify it as blood, right? What kind of an arthritis is that? What's the reason for that?
Autoimmune disease?
It's an autoimmune disease, right? So an autoimmune disease, usually 40, 50-year-old, that's the age when it starts developing. Usually it's bilateral. But osteoarthritis can be bilateral, but mostly single side, wherever the one side gets used up a little more than the other. We develop here, it's bilateral, it is autoimmune. Right? And this looks pretty harsh. A lot of times they don't have a lot of pain directly from that. If we had no rheumatoid arthritis in their background, it will be very difficult for them because of the gradual nature their nerves do break down. It's still painful, but not as much as you'd expect that.